Hello, I'm Dr. Brian Cole, and I want to thank you for allowing me to participate in the Cherry Blossom Society meeting in a virtual way. Over the next 10 minutes, I'd like to present the status of managing articular cartilage defects of the knee. My disclosures are on the AAOS website. One of the most important tenets is that decision-making when managing patients with articular cartilage disease is really not a linear thinking modality. In other words, it's multifactorial. We have to take into consideration a number of variables, including not just the cartilage injury, but all the other elements that often fall into the category of comorbidities, as you see here on the left, in addition to some of the societal impacts of the systems that they work in, whether it's a collegiate athlete or a professional athlete or just a very active individual. Many of these things have to be taken into consideration, as you see here. What's also interesting is that we know the outcome of untreated cartilage defects may be actually relatively benign. There are a number of studies, for example, at the time of ACL reconstruction that also demonstrate an articular cartilage defect that upwards of 10 years and beyond, there is no difference clinically in their outcomes. Somewhat related to this is having significant dependence upon MRI is probably not justified. We know that there's a preponderance of MRI findings in asymptomatic athletes as well as individuals. An interesting editorial by Lisa Rosenbaum entitled The Art of Doing Nothing had a great quote that said, "Patients may choose to value an MRI more than the wisdom and experience of our physicians, but this does not mean that an MRI is inherently more beneficial to our health." Furthermore, as I've alluded to, sometimes the MRI will identify lesions at a very high prevalence. Articular cartilage lesions in active patients are present in 40 to 80% of these MRIs. In addition, meniscal lesions, they also may be present and be relatively asymptomatic. What I've also learned over time is that the MRI can grossly underestimate the amount of articular cartilage damage, as you see here. The MRI on the left does show subcondylar edema, but you see a very large flap of articular cartilage delamination and degeneration that we probably wouldn't have expected based upon the MRI alone. Number 3, skillful neglect is an acceptable form of treatment. There's a great quote by Voltaire that says, "The art of medicine consists of amusing the patient while nature cures the disease." Unlike other things that we do in medicine, management of articular cartilage and meniscal deficiency in young active patients is often not a light switch. In other words, it's more of a light rheostat that reduces the level of symptoms that these patients have. It's also important for you and the patient to understand that there's insufficient evidence that suggests that sports participation will increase the risk of disease progression. Given the large ambient prevalence of osteoarthritic findings in both the hip and the knee, we do know that participation in high-level sports has no direct association with disease progression. There may be an uptick in symptoms, but there isn't necessarily a progressive disease. When managing athletes, they also have some unique considerations. For example, it's important to separate concern from disability. The inability for an athlete to perform makes them unemployable. The treatment chosen may actually affect their asset value downstream, so that also has to be considered. We're very good at improving ADLs, but we're less so at return to sport. So our best patients are those that have some degree of compromise in ADLs who also have a concomitant desire to return to sport. We often try to match the solution to the anticipated outcome and the time required to feel better to the athlete's available timeline. Clearly, arthroscopic debridement, as we'll discuss, is a short timeline that may return an athlete in a propitious way from a temporal perspective. Alternatively, ACI, or now MACI, may have a long time frame to get an athlete back given the time required for healing. We also need to choose solutions that don't burn important bridges into the future. Taking a chondral defect, for example, and turning it into an osteochondral lesion vis-a-vis the treatment might relegate that patient to future treatment with a much narrower subset of solutions. When we're asked if a patient has had previous cartilage repair procedures, how we can predict the future, one thing that we've learned is if we can get at least a year of relative pain relief and good performance after a major procedure, including cartilage restoration, many times those individuals can continue to play with the relative paucity of symptoms into the near term, say 3 to 5 years based upon our literature. We often discuss a number of options that might be available for our patients. In this graph, we see the frequency that these procedures are actually being performed. What's interesting is that there's clearly more than one way to get it done, and it may have as much to do with the comorbidities and societal factors as it does the actual procedure that you choose to treat this particular patient. Number 6, debridement is an acceptable form of treatment. We've looked at this in a variety of ways, and we think that debridement may actually lead to a more biomechanically hospitable environment where the defect itself can better tolerate the load. For example, a vertical wall versus a beveled wall may lead to reduction in contact forces across the defect. The other thing we know is that the fate of patients in our group that were otherwise going to undergo ACI, those patients who underwent biopsy, about 44% of them never went on to implantation. That's because they actually felt better after the arthroscopic debridement. We know that patients with tibial-femoral disease actually might more frequently go on to subsequent treatment, especially if they're meniscal deficient or malaligned, than, say, patellofemoral lesions when we're performing debridement. Marrow stimulation and its adjuncts have evolved and remain in a very effective first-line treatment strategy. We've learned over time that athletes can get back in various sports at a high level if the rehabilitation is abided by postoperatively. We also use a drill, as you see in this video, rather than an awl more frequently, mainly because the subchondral response to an awl is actually much more robust. It's almost like a fracture response. And what we know is their postoperative MRIs may actually look more quiet after drilling versus microfracture awl. We also recently published a series of patients who underwent awl microfracture versus drilling and showed that the revision rates were statistically higher in those who underwent awl treatment using marrow stimulation versus those that were drilled. Finally, we have a number of options that are available to us that are adjuncts to marrow stimulation. This is a procedure called AutoCart, where we take articular cartilage from the intercondylar notch. We collect it into a receptacle that you see here that's connected to the shaver. We mix it with biocartilage or allogeneic articular cartilage that's dehydrated. And then we add bone marrow concentrate or PRP and use it as a scaffold to carry these growth factors into the lesion as an adjunct to marrow stimulation. We'll then seal this with fibrin glue after it's applied to the defect. Early clinical evidence suggests that the repair tissue may be more formidable compared to marrow stimulation alone into an empty defect. Number 8, what's critical is that these patients don't always present with an articular cartilage defect, but have a number of comorbidities, as you see here. So somewhere along the treatment continuum, we must treat all comorbidities, and that most commonly is malalignment and meniscal deficiency. We commonly will talk about the use of orthobiologics. I would caution and say that these should be used judiciously. There still remains a paucity of high-quality studies, but the preliminary results are encouraging. To date, there's not enough to recommend routine use at this time. And finally, I think it's critical to manage patient expectations. It's important to know not only the literature, but to know your own experience. We've looked very carefully at the results of non-operative treatment for patients who have articular cartilage disease and osteoarthritis. We will not uncommonly utilize PRP and hyaluronic acid at the same time in a series of 3 injections to treat the symptoms of articular cartilage disease as a non-operative treatment approach. We know that we can see successful outcomes in competitive athletes, sometimes to the frequency of 75 to 85%. We also know that poor outcomes occur, and up to a third of patients undergoing cartilage repair might require reoperation. We've learned 2 things about our poor outcomes. One, if a patient undergoes arthroscopic debridement, that they may actually have about a 60% chance of reduction in their symptoms, not requiring revision. And 2, we also know that the odds ratio to go on to knee replacement is actually much higher in patients who do require subsequent arthroscopic debridement. Thank you for your time, and if you have any specific questions, you can always reach me directly by email. Thank you very much.